Hello, my name is Chief Timothy Grenno, and welcome to Chief Talk. This is a local show that we film at the Whitman Hanson Cable Studio that we cover different aspects of the fire rescue services with the town of Whitman. Last month we had Chief Andy Reardon from Norwell on, and we spoke about fire prevention. After that show, I did have some requests from some of the viewers that were interested in a few different topics, such as emergency medical services, how we operate the ambulance service in the town of Whitman, and how that interacts with the fire service as it is one operation. So who I brought with me is Matthew Busch. He's a firefighter paramedic in the town of Whitman. He also serves as the town's emergency medical service coordinator. His day-to-day functions is to basically work with the ambulance side of the department, work with the department like EMTs and the paramedics who staff those trucks, and make sure that their credentialing is all good and their training is up to speed and the equipment. Thank you for coming here today, Matthew.
Thank you for having me.
I think probably the best way to start this out is let's talk a little bit about what an EMT is and what a paramedic is, because some people think that they're one and the same.
Okay. Well, what an EMT is, it's an emergency medical technician. They go through approximately 300 to 400 hours of training on basic life support skills. The paramedic is a lot more advanced. They go through approximately 1,000 hours of training, and they're trained in all aspects of emergency care, everything from advanced airways to administering emergency medications, doing EKG recognition in the field, and transportation of specialty care patients to local hospitals.
So if we look at the basic EMT level, which we all started at way back when, things have really changed and progressed in the EMS world with the training levels and the duties and statewide treatment protocols as to what each level can do. I went through medic school in '95. I went through basic school in '87. You went through it not too long after me, I think, 2000 or something like that, or '99.
I got my EMT certification in 1995 and my paramedic certification in 1998.
So let's compare the progression of EMS from back when we went to school to what we're responsible for now. Because even though we went to school back in the late 80s and early 90s, we're still responsible for the current data and the current treatment protocol. So let's take a little trip back into history and look at what we did back then and what the workload is now is probably the best term as to what we're responsible for.
Yeah, absolutely. Back in the early 90s, late 90s when we first started our paramedic service at Whitman Fire Rescue, we stuck to a certain protocol that we had to follow on a regular basis to treat certain conditions. Over those years, we've earned the trust of the physicians, and we're able to expand on those protocols a lot without having to call and talk to a doctor for every little thing that we do. Now it's pretty routine to run a complete call without speaking to a physician at all, whereas in the past we used to have to call for a lot of little things, such as administering certain medications or performing an advanced airway when needed. And currently we don't have to do that. We can just work on a standing order and continue to provide patient care. So
Whitman Fire, we only have one basic EMT. We have one intermediate level, which is kind of a like in-between level that can administer like IV therapy and like intubate. That is going away with the new national criteria. And the other, I believe, 19 members of our department are all paramedics. So why don't we run through, Mrs. Smith from 123 Main Street is having chest pain and she dials 911. Let's go through that sequence as to what Mrs. Smith is going to see from us for response and treatment. And what is our treatment doing to assist Mrs. Smith that between her house and the hospital, okay, I guess.
Basically, upon receipt of the call for somebody having chest pain, the paramedic's already going to be presuming that there's a possible cardiac condition. When we arrive on scene, the paramedic's going to start to ask the appropriate questions. How long have you had the pain? What kind of pain are you having? Is it a sharp pain, a dull pain? Do you have any cardiac problems, or have you had any pain like this before in the past?
Now, just to step back, two things. Why the time and quality of pain? Why are those so important?
Well, it's so important because we now have early notification for anybody having a myocardial infarction. We're able to notify the hospital on how long that pain has been going on and how advanced potentially the person's condition will be.
Okay. Okay. Go on. Sorry.
So once we determine, what type of pain that Mrs. Smith is having, we're going to perform a test called a EKG. It takes a multifocal picture of the heart, and paramedics are able to interpret whether or not the patient is having an MI, as we call it. And if that patient was having an MI, we're going to immediately notify our local hospital so they can be ready to treat the patient as soon as we walk in. Most likely, in the presence of an MI, that patient's going to receive what they call cardiac catheter placement. Sometimes that takes, anywhere from 20 to 90 minutes to set up a room so that the person receives the appropriate care as fast as possible. She's also going to receive from the paramedics that arrive on scene oxygen therapy. We're going to treat any respiratory conditions. We're going to establish an IV on the patient and administer any appropriate medications that we feel are due to her condition.
So when somebody is suffering from chest pain or starts to experience chest pain, they may feel that it's nothing, that it's indigestion, that it's heartburn or whatever. But the reality is that time is muscle. And no matter what age bracket that you might be in, if you start to experience mid-sternal chest pain, arm pain, a little nausea, or any of those symptoms along, the most appropriate thing to do is to dial 911. Because like we said, time is muscle, and getting that patient from their home with our treatment to the emergency room into the catheterization lab is the most critical part.
Absolutely.
The most critical part. And I think that we have a very good track record. I've looked at our stats, and the majority of our, or a lot of our cardiac patients see the cath lab with very great outcomes.
Yep, absolutely. Our local hospital that we transport to, Brockton Hospital, we have a great relationship with them. We're actually have the advanced technology now that we're transmitting our EKGs directly to the emergency department, also to the cardiologist that's going to be performing the procedure. So they know what type of MI the patient's having. There are various types. And we strive for a 90 or minute less time to have that patient's vessel opened. So, time is essential, and any little deviant from that can have a negative outcome.
Let's talk a little bit before we go into the technology that we use. Let's talk a little bit about what the blockage is and what type of damage that does, and why that 90-minute time is so critical.
Yeah, what they consider is any sort of blockage that's in the heart that is inducing an MI. Once there is a complete occlusion, there's no blood flow to that part of the heart. That heart needs blood flow through it before it dies. Your heart is a big muscle, and without blood flow to it, it will die. And that's when we have very negative outcomes. So the faster that we can open that vessel and allow blood flow to the affected part of the heart, the minimal amount of damage done.
Very good. Very good. So let's talk a little bit about the technology as to how we now can diagnose what's going on in the field and what type of machine that we use. And what I'll do is I'll explain a little bit about the ambulance revenue account, which is the account that we have, which when we transport a patient, we obviously bill their insurance company. And when the checks are received from the insurance company, it goes into a separate account, which is called the ambulance revenue account. That account is used for all of the capital expenditures within the fire department, including fire trucks, and on the EMS side of things, it buys ambulances and it buys equipment. About 3 or 4 years ago, Physio Control, who makes the devices that now we use, upgraded their machines, and we spent close to $95,000 on 3 new machines. If you want to talk a little bit about those machines, the Lifepak machines, and what they are capable of doing.
Yeah, the Lifepak machines that we're using, we're currently using the Lifepak 15. It's a multifaceted machine that interprets EKG findings. It also does automatic blood pressures on patients, body temperature. It has a built-in thermometer on it, pulse oximetry, as well as end-tidal CO2 monitoring.
Let's talk a little bit about what pulse oximetry and end-tidal CO2 is for the patients, because our next topic is probably about our COPD patients and asthma patients and stuff like that.
Yeah, so pulse oximetry monitors the level of oxygen that's in the blood. It takes an infrared reading from a device that's attached to the finger, and it gives you a reading of, based anywhere from 80 to 100%, 100% being the best. Obviously, we want to maintain a patient's oxygen level in between the 90s and 100s. End-tidal CO2 is a newer reading that we're using, and that actually determines the amount of carbon dioxide in a patient's bloodstream. We want that level to be, somewhere between 35 and 45 is a reading on our monitor. If you have somebody who is retaining that CO2 level, it's going to be elevated. It's going to be above that 45 mark, which helps us determine, somebody with a respiratory problem, which way to approach them. If it's on the lower side, they may be hyperventilating, or they may have a condition called congestive heart failure, and not necessarily retaining that CO2, which we would see in a COPD patient, for example. So that reading is very important on how we're treating our patients. It's and that's now built into our Lifepak 15s. Our Lifepak 15 also, like we said, does our 12-lead EKGs, and it will assist the paramedic in giving interpretation. We don't go by that interpretation all the time, because you can get a false reading on it.
Correct.
That falls back on our training to be able to recognize that.
So just so people know what a 12-lead EKG is when you go to your primary care for your yearly physical, or if you're not feeling well, if you're above the age of, I think, 40 now, they do EKGs on everybody. So the EKG that they're doing in your primary care office is the same EKG that we're doing in the field. It's just a smaller version of it.
Correct.
So.
Yep. And we're doing it on an emergent basis.
Correct.
We're not doing it. We do it routinely on anybody who is, complaining of certain symptoms. If they're having shortness of breath, if they're having chest pain, even
because there are such things as silent MIs.
That's correct.
Especially in diabetics.
Yep. Even a patient having abdominal pain, or just somebody who just doesn't feel right, we'll perform a 12-lead EKG to rule out the fact that they may or may not be having an MI.
Right. And to speak a little bit on the silent MIs, and back when I was in the field, 10 years ago or so, I forget who I was working with, but we had just that case. We had a elderly patient who just didn't feel good, who was a diabetic, and we loaded him up and we worked him up, and we put the patient on the monitor, and they were having a huge MI. And from their signs and symptoms, you would have never known it until you did the EKG, and that's part of our training, is to read those, and the patient was having a huge MI.
Yeah, it's definitely progressed to a routine level of care,
right.
And we're doing them a lot more than we ever have in the past, just because we have the technology to do it, and the ease of doing it is there.
So our paramedics are basically bringing the emergency room to the person's home.
Yep, absolutely.
If you call 911 because you're having any type of medical emergency, we're bringing 90% of what they're going to be doing in the emergency room to your home and starting that procedure.
Yep, absolutely.
You know, short of suturing and stuff to that effect. And we are pretty much the eyes and ears for the physicians, so we're giving them the heads up on the way over after we've started treatment, which another issue that we see a lot of in Whitman, or like another like illness, is respiratory patients. We have a very high elderly population in the town. A lot of the people work back in the day of the foundries and everything else, and they all have COPD, and a lot of the younger kids have asthma. So let's talk a little bit of how we treat a chronic COPD patient, or say like an acute like asthmatic.
Yeah, so nowadays, anybody who has a respiratory problem, we're using that end-tidal CO2 monitoring to help us determine whether or not, you know, they're having an asthma attack, a COPD patient, based upon their history of, you know, were they smokers, were they exposed to, you know, the foundry asbestosis. In our elderly population, we do tend to see a lot of that. Mm-hmm. Where our younger population that has respiratory problems, they're most likely asthma due to the, you know, decrease in the amount of people that are smoking nowadays.
Now, if we throw the third facet into it with congestive heart failure. So there's 3 respiratory issues that we generally see in Whitman: mm-hmm. COPD, asthma, and then well, it's more of a cardiac issue, the congestive heart failure. Mm-hmm. But this is why ECO2 is so important, looking at CHF over here and the COD patient over here, and how you go about your treatment.
Yeah, absolutely. A lot of those respiratory illnesses can mimic one or the other, and we need to be able to differentiate, you know, what we're treating for, because we give certain medications for congestive heart failure, mm-hmm. Versus, you know, in an asthmatic or a COPD patient, we're going to administer albuterol and Atrovent to that patient, where if that patient was actually in congestive heart failure, it could actually make their condition worse, which we don't want to do. So our patients that we're seeing with these respiratory illnesses, we now have the devices to help us differentiate. So when we start an IV on these patients, especially our COPD patients, we're going to administer medications such as albuterol, Atrovent, in a little bit higher dose than they normally have at home. We can actually start administering steroids to these patients, where 5-6 years ago we weren't allowed to.
Right.
So we administer a steroid to these patients and decrease their chance of, you know, long-term stay in the hospital. There are other devices that we have. We have a new airway. It's called CPAP, or continuous positive airway pressure. That it's a mask that we place on the patient, and that helps keep them from ever being put on a ventilator. If their condition gets to a point where the CPAP isn't working anymore, then they would have to be put on a ventilator. But the CPAP is definitely decreasing the amount of patients that get put on ventilators and decrease their hospital stay.
And looking at the progression of EMS over the past 20 years or so, everything is geared towards better patient treatment, obviously, and lesser hospital admission time. Mm-hmm. Because when you look at the healthcare system in the United States, or if you look at the healthcare system in Massachusetts, you know, a lot of the inpatients in hospitals were, or still are, readmissions. So the treatment that we're giving in the field so early on, moving them through with CPAP and everything else, 10 years ago, we didn't have CPAP in the field.
Correct.
And what would basically happen to, say, a COPD patient who was like acute, or a CHF patient, we would go through the drug box and give them what we could give them, and the last resort was to place a breathing tube like down their throat and put them on a vent, and they would be on that vent for 3 or 4 days. Mm-hmm. And then the hospital would have to wean them off that tube, which takes another couple of days, and they're looking at a 2-week admission time.
Correct.
Now with CPAP.
Yeah, with CPAP, we're putting these patients on CPAP. They're continuing the CPAP in the emergency department, and the patient may only spend 1 or 2 days in the ICU and be discharged to a rehab or potentially even home.
Right.
So it definitely decreases, the hospital stay in the event of readmissions.
So let's talk a little bit about maintaining our credentials. What's involved now compared to what we did 3 years ago and 10 years ago?
Well,
because the pressure's really coming on us to maintain our certifications.
Yeah, absolutely. We're held to a higher level of care now, and there's much more emphasis on our education.
As there should be.
Since Massachusetts has transitioned over to the National Registry, they are focused more on exact education of what we're doing in the field. And we determine this by the number of calls that we do, the types of calls that we do, and they have giving the EMS officers leeway to train on those exact topics.
So if we do 1,600 calls a year for medical emergencies, and 800 of those, and these are just numbers I'm just making up, and 800 numbers of those are respiratory patients, you can now focus your training around respiratory patients and the different aspects of respiratory and what to key in on.
Yeah, correct. Whereas before, you were required to do education on X, Y, and Z.
Right.
We're now able to give some specialized education on specific topics. That's done through a 30-hour core curriculum class that paramedics are required to take every 2 years. We also are required to take a minimum of 10 hours of continuing education through our medical center at Brockton Hospital. Basically, they're called M&M rounds. We're required to meet with a physician, 10 hours a year to discuss, different topics in EMS as well as the types of patients that we've brought into the hospital. We're also required to maintain our CPR certification every 2 years. We have to maintain a pediatric advanced life support certification that is done every 2 years. It's an 8-hour program every 2 years that we have to maintain, as well as advanced cardiac life support. That's also another 8-hour program we have to do every 2 years. So there definitely is a lot more education than we've had to do in the past.
And on top of all those, you've got your 30-hour of national requirements, plus you still have 30 hours of elective hours that you have to do, correct?
That's correct.
Within a 2-year period.
Yep.
So on top of everything on top of the 30-hour core that's done every 2 years, on top of the M&M rounds, and ACLS is now added into that, but we still have to do another 30 hours of what they call elective hours.
Correct.
To maintain certification.
Yep, so there's basically we have to maintain 60 hours of education in a 2-year period. We tend to go above and beyond that due to the amount of certifications that we have and requirements that we have within the department. But I think it's a great thing to maintain our certifications to the highest level possible.
Okay. Let's talk briefly about, because we are getting close on time, so I told you that the 30 minutes would go by like that. I do have an article on town meeting this year to purchase 2 Lucas devices. Let's talk a little bit about what a Lucas device is and why it's so critical that we purchase 2 of them.
The Lucas CPR device, it's basically a hands-free device that is a machine that we put on to a patient who suffered a cardiac arrest. It administers chest compressions at a predetermined rate, which is the appropriate rate of upwards of 120 a minute at the proper depth of compression. One big problem they found with CPR is that patients receiving CPR done by a paramedic or an EMT or a bystander, there's a huge fatigue factor, so the quality of compressions aren't always met, and by that happening, we were having to swap out people doing chest compressions on a regular basis.
I believe the studies I saw said that pre-hospital cardiac arrest patients have approximately a 5% chance of survival. So if you're at town hall and you collapse in cardiac arrest, you're already behind the 8 ball, because your chance of survival per statistics is only 5%. And the same study that was speaking about the Lucas devices said something about human chest compressions generally drop off after the first 60 to 90 seconds, and become erratic because of the fatigue factor.
Correct.
So what this device does is this takes all that over.
Yes, it does.
And this performs specific, proper depth, proper rate chest compressions on that patient who's suffering from cardiac arrest.
Yeah, it does that, and it also allows the provider that's in the back of the ambulance to perform other tasks because they know that chest compressions are being done adequately, and you have more members to concentrate specifically on the patient at hand and monitor their situation more closely. I
think the study also said that that by utilizing of that Lucas device, it's also increasing patient blood flow by 40%.
Yes, yep.
From that effect.
Absolutely is.
So it shows that one specific tool is a huge life-saving device.
Yes, it is.
So it's all about technology in the back of the ambulance. It's about having the best of the best, which I think we do. I think our guys do a phenomenal job. I think that they're well trained and that they perform professionally and admirably. And as chief of department, I try to give them, through you, the tools that they need to do their jobs. So we have the Lifepak 15s, which can do pretty much anything that we need them to do that's in the hospital. Yep. By adding these Lucas devices, I think that it's a great addition, I would say, to help in patient care and to better us in what we do in the field.
Absolutely. It's becoming the standard of care. Our patients expect the best from us, so we need to be able to provide them with the best.
Right. So as we're winding down, that I think we covered basically what an EMT is, the difference between an EMT and what a paramedic is, and we staff 2 ambulances, both with paramedics on them. We have a 3rd ambulance who is a reserve truck that if we have adequate staffing and stuff and that 3rd call hits, then we send that truck out. So that's being said, I hope that we answered the questions that are out there about how we operate the ambulance service in Whitman. The firefighters are dual trained firefighter paramedics. So if there's a fire call, you take the fire truck. If there's an ambulance call, you take the ambulance. And we generally have a 4-minute response time to anywhere in town. So like I said before, I think that we do a fantastic job.
Yep, we do.
I'm very proud of our department, and I'm very proud of what we do. If anybody has any questions for or suggestions for future shows, then I ask you to go to our department website or to the town website and shoot me an email. Coming up in our next show will be our safe officer, Tom Ford, to speak about student fire education awareness in the school system and senior fire education awareness, along with the opiate and drug issue that we're seeing on the South Shore here. So I thank you very much for joining us, and have a safe day.
That moment? It was a moment that changed my life. I'd been training with my team for months, and now we had been called up for the first time. The real deal. Wildfires were getting dangerously close to homes. At that moment, I got my first taste of just how important the Guard is to my community.
See how the Guard can be an important part of your life at NationalGuard.com.